I'll be taking station 6 for the April 2021 practice questions. We had about 5 scenarios painted. I'll just rush through them. The first is a 28-year-old female. She had skin lesions on her hand, fever, vomiting, passage of dark colored urine, and reduced urine output. The second scenario was a 34-year-old who was placed on over-the-counter drugs and had a 3-day history of progressive reduction in urine output. The third scenario, a young man who had a robbery attack 3 days ago with elevated creatinine, had hematuria and epithelial cells in his urine as well. Version 4 and 5 were about the same thing. A diabetic who was kidnapped 4 days ago, was beaten, brought unconscious, and had reduced urine output and dark colored urine. So what was common in all scenarios was the fact that they all had reduced urine output within a short period, within days, 3 to 4 days, with different reasons for the symptoms they were having. So we'll start with the first question. It says, what other questions would you like to ask? So I categorize them into different aspects. First is to ask questions that would enable us to characterize oliguria or anuria, as the case is, because it could be abrupt or gradual. And in any of the cases, the causes differ. If you're having an abrupt onset of oliguria, the things that will come to mind are things like acute severe glomerulonephritis or a renal artery emboli. But if you have a history that's suggestive of a gradual oliguria, then we start to think urethral strictures, bladder outlet obstructions, as in BPH. Also, we would ask questions around the symptoms to rule out chronic symptoms, because it's not enough to have an acute um, 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 scenario painted and then we rule out completely a background chronic kidney disease. So we want to find out if this is more like an acute on chronic picture, to ask for questions suggesting chronicity, fatigue, weight loss, anorexia, pruritus, paying attention to the duration. Also want to ask history that would suggest the etiology. This is like where the meat of our history comes to play. So is there low fluid intake, anything suggesting gastroenteritis, vomiting, or passage of loose stool? I think the first version 3, the patient also had some form of diarrhea and vomiting. Or is there hemorrhage, which would suggest volume loss as the cause of the AKI? Then very important is to find out history surrounding the drugs the patient has been on, NSAIDs, aminoglycosides. And when we go down, we also see other drugs that can actually cause intratubular obstruction. So taking a very good drug history is very key when we're trying to manage AKI. So if we think the patient has been on some drugs, NSAIDs or aminoglycosides, then we start to think nephrotoxicity as the cause of the AKI. Then we also want to find out, ask questions around infection, especially for skin and throat infection, any past history of any of this, which are the first scenario, she had skin rash and all on her hands. So taking a history around infections in the throat or the skin is also very key. Then any history of radiologic procedures that involved use of iodinated contrast agents the past week. That's also very important because that has to tilt our mind towards a contrast-induced nephropathy. Then history of trauma or unaccustomed exertion like excessive exercise, which would tilt our mind towards rhabdomyolysis. The fourth and the fifth scenarios painted something in keeping with this. One was the one who had a robbery attack, and then the other one who was kidnapped, possibly was beaten. And so rhabdomyolysis comes to mind. Then history of blood transfusion, we're thinking hemolysis, which will give you hemoglobin in the urine and cause some form of kidney injury. Then ingestion of toxins like ethylene glycol, that's also important. We also want to find out any exposures to heavy metals, mercury, especially when we're dealing with patients who we think are welders or miners. So this brings to mind the importance of asking the occupation of the patient and also asking for use of mercury-containing products. This would also help us decipher what the possible cause of the AKI is. Also important to ask history of comorbid conditions that we think would increase the risk for developing AKI, as simple as things like hypertension, any heart disease, congestive heart failure, liver pathology, chronic infections, connective tissue disease, pelvic or abdominal malignancies, gynecologic surgeries. History of all of this, we need to tilt our minds to things that would put the patient ab initio at risk for an AKI even before the insults. So the big question is, what is your diagnosis and how would you investigate? So I just picked for each of the versions what the picture looked like. For version 1, she had a skin rash, vomiting, fever. So the picture was more of an intrinsic AKI, most likely post-streptococcal glomerulonephritis. Version 2 seemed more like an intrinsic AKI to likely an acute tubular necrosis or possibly an acute interstitial nephritis because he had been exposed to over-the-counter drugs. And when we have over-the-counter drug use, either NSAIDs or maybe an aminoglycoside, these are the things that come to mind. Version 3, most likely intrinsic to, that was the one who was beaten and had a robbery attack. So rhabdomyolysis is in the picture. A pigment-induced acute kidney injury is likely. Version 4 and 5, the diabetic who was kidnapped for 4 days, very likely he might have gone into some form of hyperglycemic crisis. Dehydration is somewhere in the picture. So it's a mix of a pre-renal and as well pigment-induced AKI. But some points I would like us to note when we're making a diagnosis of AKI is if you have an elderly patient who has mental status changes, commonly what comes to mind is pre-renal or a normotensive ischemic AKI, either from restricted fluid intake and as well insensible fluid loss, which I think can be the case in the diabetic, because for me, I just felt he would be an elderly patient, and of course he was brought in unconscious. So definitely there's over the counter
Hello, Dr.
use.
Thomas. Okay. Hello, Dr. Thomas.
Yeah.
Yeah, we lost you for about 10 seconds.
Okay. Sorry. Can you hear me now?
Yes, we can hear you now.
Okay. So I'm still on the diagnosis. I wanted to just paint pictures for us that would help us quickly think through whatever scenarios we're given. And so I was talking about the diagnosis of intrinsic or ATN, and that's seen very, very commonly in patients who have drug overdose, sepsis, hemorrhage, prolonged hypotension from cardiac arrest. You have a patient who has fever, rash, arthralgia, exposure to certain medications like antibiotics, NSAIDs. Then we start to think possibly an allergic interstitial nephritis or acute interstitial nephritis like the patient we had. And all of this, is still pointing towards an intrinsic AKI. The diagnosis of post-renal AKI from obstruction is likely in patients who are elderly, an elderly male with urgency, frequency, hesitancy, posturing, a female with history of gynecologic surgeries or abdominal pelvic malignancies. We start to think also post-renal AKI from obstruction. Then very importantly, these drugs listed down here, indinavir, sulfonamide, acyclovir, methotrexate, triamterene, all have a risk for forming crystals within the tubules. So they are culprits for intratubular obstructions that will still give us a post-renal picture, post-renal AKI. And when we go down to the analysis, I'll be able to show us the kind of crystals we have for this kind of drugs. So the other question was, how would you investigate? So I divided it into investigations that would be able to assess the etiology. And importantly here is a kidney function test, looking at the electrolytes, but importantly is the urea and the creatinine. Increased serum urea and creatinine are the hallmarks of AKI. So when we're looking at the renal function test, we're looking out for the ratio of the BUN to creatinine, and any values greater than 20:1 is in keeping with the pre-renal AKI. We'll look at the table that differentiates that later. Also, urine chemistry is very important. We're looking at urine sodium, urine urea, and the creatinine. But two important indices that we look at are fractional excretion of sodium and also fractional excretion of urea. And these are the calculations. But if we have a fractional excretion of sodium that is less than 1%, then we're thinking pre-renal AKI. And that's what we get because the tubules are functioning. So they're able to reabsorb sodium. And so you have less of it in the urine as against an intrinsic AKI where there's tubular damage. And so sodium is lost in the urine. So you have values greater than 1%. Fractional excretion of urea is also very important, especially in patients who are on diuretics, because the diuretics will not affect urea transport as it will for sodium. So when you have a patient who is on diuretic, the preferable indices to use is the fractional excretion of urea. And if you get values less than 35, and that's suggestive of pre-renal AKI, but if it's greater than 35, then you're thinking an intrinsic AKI still because there's tubular damage and then urea is not absorbed as it's supposed to. So you have a lot of it in the urine in intrinsic AKI. Other investigations that we can do, very important, is the full blood count with the blood film. This can show elevated white blood cells, which would tilt our mind towards an infection. Low PCV in acute blood loss. If we find schistocytes on the blood film, then we're thinking hemolytic uremic syndrome or thrombocytopenic purpura. If we find rollo formation, then our mind starts to tilt towards multiple myeloma alongside if we see uric acid crystals. Then thrombocytopenia will tilt our mind towards maybe a portal hypertension or a thrombotic microangiopathy. Also, very important to do is serology. We're looking at hepatitis B combo and anti-HCV. If we remember, there are different types of glomerulonephritis that we can see in either B or C, hepatitis B or C infections. So this is very important to do. Other serologic investigations are anti-streptolysin, complement levels, and antibody assaying, anti-nuclear antibodies, ANCA, and glomerular basement membrane antibodies. Something that we can also do, which is not commonly done, is to check the bladder pressure. And if we get values that are greater than 25 millimeters of mercury, then we start to think abdominal compartment syndrome. And that's something we can consider in the boy who had a robbery attack, because I'm sure there'll be some blunt trauma to the abdomen, and then he's also at risk for having abdominal compartment syndrome. So this can also contribute to the AKI alongside other causes that we had discussed. Other things we can do are investigations to assess the extent of the disease and complications. So we can do a renal ultrasound to detect existing renal disease or obstruction of the urinary tract. L2 renal angiography. This would also help to make a diagnosis of renal vascular disease. We can also do radionuclide imaging, although this is not very helpful when it comes to AKI because we have issues with blood flow already. So it might not be very helpful. Kidney biopsy can also be done, especially when we're not sure of what the diagnosis is, and when we think a change in the treatment would actually bring a different result or help make the patient better, especially if we think we need to initiate immunosuppressives as in maybe an autoimmune disease, then we can do a kidney biopsy. I just wanted to throw more light on emerging biomarkers that we can use for risk stratification and prediction of AKI, because creatinine would only start to get elevated when we have lost 50% of renal mass. So it's quite a late indicator to use if we really want to be proactive in the management of AKI. So these are some biomarkers that are coming into the clinical practice that can be used to predict early, AKI. So I'll just leave that for want of time. The third question is, how will the various factors contribute to AKI? So I divided this into pre-renal AKI, renal AKI, and post-renal AKI. So if we have a pre-renal AKI in our minds, the possible factors that could lead to AKI is the fact that in pre-renal AKI, there's reduced blood flow to the kidneys, either as part of systemic hypoperfusion from hypovolemia, or there's a selective hypoperfusion to the kidneys, as we see in renal artery stenosis or aortic dissection. So these are some examples: hypovolemia, hypotension, renal vasoconstriction, glomerular efferent arteriolar vasodilatation, and the different things that could lead to this. And if we look through, you see that all our patients can fit into either of the scenarios that I've listed here. For intrinsic or renal AKI, there's either a glomerular or tubular injury associated with cellular damage. The thing in intrinsic is that there is damage to the cells, either the tubular cells or glomerular cells, and so it leads to ischemia. And sepsis, nephrotoxins, prolonged ischemia are very common causes of intrinsic AKI. The different forms include acute tubular necrosis, acute interstitial nephritis, glomerulonephritis, intratubular obstruction. And if you look, the scenarios we painted can actually fall, especially under acute tubular necrosis. If you have prolonged prerenal injury, in the long run, there'll be ischemia, and then the patient goes into acute kidney injury. Drugs like vancomycin, amphotericin B are also culprits. Rhabdomyolysis and intravascular hemolysis are culprits as well for ATN. Acute interstitial nephritis, drugs like beta-lactam, antibiotics, penicillins, NSAIDs, proton pump inhibitors, infections like pyelonephritis are also culprits for causing acute interstitial nephritis. I'll just run through to the post-renal AKI. For post-renal AKI, the factors here primarily is obstruction. And what happens here is the obstruction leads to congestion and urinary backflow into the filtration system. So what we would have in the long run is there's reduced renal perfusion, some background inflammation, tubular atrophy, and then interstitial fibrosis. But it's important to note that 2 hours within the obstruction, pathologic disturbances are already setting in. And post-obstructive diuresis occurs in 50% of patients. So even when we have a patient who has post-renal AKI, it's important to look at complications like hypovolemia and dyselectrolytemia while we're treating. So common examples are renal or ureteral calculi. Bearing in mind struvite and cystine stones, they grow very rapidly and are culprits for causing obstruction. Tumors, blood clots, neurogenic bladder, prostate enlargement, which is very common in our environment here. These are all possible factors that can contribute to development of AKI. Now, how will you manage the patient? The principles of management are listed down here, but one thing for us to note is the treatment of AKI should commence even before the diagnosis is established. So it requires a very high index of suspicion. Once we think it's AKI, let's start doing what we need to do to get the patient out of it quickly before damage is done. So ABC of resuscitation should commence. And then if we identify life-threatening conditions, we need to stabilize quickly. Like the patients we had in version 4 and 5, who was diabetic, very likely that he would have one of the diabetic emergencies, most likely HHS. So in such a patient, we want to quickly check the sugar levels and tackle whatever the life-threatening condition is at the time. Septic shock will manage as promptly as possible. Fluid management is very key in AKI. Our goal is to reverse hypovolemia with rapid fluid infusion, correct fluid overload with intravenous furosemide in patients who are hypervolemic. Also correct electrolyte imbalances, especially hyperkalemia. Those who come in with metabolic acidosis or hyperphosphatemia will manage appropriately. Then treat underlying conditions. If it's sepsis, we treat heart failure. If there's an obstruction, we call in the surgeons and a surgery is done. Because if we think it's post-renal, if we don't take out the obstruction, there's no winning for us in managing the patient. Autoimmune conditions, we treat appropriately. And then to prevent and manage complications, there's room for short-term renal replacement therapy, especially if we think the patient has complications like uremic and pericarditis or volume overload that is refractory to medical therapy. So for the fluid correction, if we think the patient is overloaded with fluid, we give high dose of intravenous furosemide at a dose of 1 to 1.5 milligram per kg. But it's important to note that the diuretics will not increase urine output if the patient is not hypervolemic, and will also not convert an oliguric AKI to a non-oliguric AKI. If we're treating if the patient comes in with hyperkalemia, then we want to manage First is to decrease the intake of potassium-rich diets. Also, we can give insulin, dextrose solutions just to help with intracellular shift of the potassium. Beta agonists like salbutamol is also there on the list, but I think what we do commonly is the insulin and dextrose solution approach. We can also use potassium binding resins, and then dialysis comes into play for treatment of hyperkalemia when it's refractory to the other methods. So if we also have hypophosphatemia, we can use phosphate binders. If there's metabolic acidosis, we can use bicarbonate or citrate buffers. But where the metabolic acidosis is not so severe, sometimes with good fluid management, the metabolic acidosis gets corrected. Treat underlying cause. If it's sepsis, we give antibiotics. If it's heart failure, we give anti-failure regimen. Importantly, sepsis and heart failure, we know in both conditions, there's some level of vasodilatation, especially in sepsis. And so there's renal hypoperfusion, and then in the long run, ischemic injury to the kidneys, obstruction. We can do surgeries or lithotripsy for calculi. If we think there's a vasculitis, then we can give immunosuppressive medications. Renal replacement therapy in AKI comes into play, especially when we've given medical therapy and we're not making any headway. Options include intermittent hemodialysis, or we can do a continuous venovenous hemodiafiltration. This is particularly important in patients who are hemodynamically unstable. There's also the option of peritoneal dialysis. But the other question we would be asking is what are the indications for renal replacement therapy in AKI patients? Volume overload that is not responsive to diuretics, hyperkalemia, and acid-base disturbances that are also refractory to medical therapy, severe uremia or azotemia. The question E is, what is the pathophysiology of AKI? So I just use these diagrams to be able to explain what happens really when we're talking AKI. Irrespective of what the cause is, pre-renal, renal, post-renal, they all meet at a particular point. If you have prolonged pre-renal AKI or even pre-renal injury, already there's some degree of renal hypoperfusion. If it's prolonged, it will lead to ischemia. If it's renal, either from nephrotoxins or endotoxins from sepsis, there's a toxic injury to the kidney. Even from the post-renal angle, over time, we have some reduced renal perfusion. So they all meet at the center here, where there's ischemia, toxic injury. Sorry. But the important thing that plays out is the inflammation, vascular injury, and tubular injury. There's direct tubular injury from the neutrophils and macrophages, recruitment of these cells, and then also release of cytokines and chemokines that also cause injury to the kidneys. Also important to note is that some of these chemokines and cytokines also mop up nitric oxide and then further leads to renal vasoconstriction. There's also vascular injury, endothelial dysfunction occurs, there's microvascular obstruction, vasoconstriction, which I already talked about, coagulopathy. All of this is what we find when there's vascular injury. Also, there's tubular injury. Important to note in tubular injury is the loss of the brush border and loss of cell polarity. This is what actually leads to the proteinuria, because once the polarity at the borders are lost, then it's very easy for protein to be lost in the urine. So what we need to understand when we come to pathophysiology is the fact that there's inflammation, vascular injury, tubular injury from either ischemia, toxins, or sepsis, as the case may be. Question F is to distinguish between pre-renal and intrinsic AKI. This table just explains all that we see from the history to the clinical presentation to the laboratory studies. The history would suggest in pre-renal some gastrointestinal loss or skin volume loss or blood loss, while for renal AKI, use of drugs or toxin or sepsis or even prolonged pre-renal injury can lead to a renal AKI. The clinical presentations, usually there'll be hypotension, volume depletion. For the renal AKI, it won't be really specific because damage has already been done. So what we'll be seeing is just a reflection of what's happening in the kidneys. Very important to note are the laboratory studies, the ratio in pre-renal AKI, the ratio of BUN to creatinine is usually greater than 20, but less than 20 in renal. The sediments that we see in pre-renal, we could see hyaline cast, which is normal, but in renal, we have the classic brown, muddy brown cast or granular cast. The urine osmolality is usually greater than 500 millimoles per kg in pre-renal, but less than 350 in renal. The urine fractional excretion, which I already talked about, of sodium is less than 1 in pre-renal, but greater than 1 in renal. Then also here we can appreciate the novel biomarkers, which I talked about, which we would see in the renal AKI. So if we go through the table, it kind of just gives us a very good overview of how to differentiate either of the AKIs. Now, the other question is, what are the possible findings on urinalysis of the patient? Urinalysis, including microscopy. I just painted scenarios. If we have myoglobinuria or hemoglobinuria from rhabdomyolysis, which we saw in one of our patients, the urine will be reddish brown or color colored passage of color colored urine, and then there'll be positive dipstick for him without any red blood cells on microscopy. Significant proteinuria from tubular injury, which I explained from the pathophysiology. Once there's tubular injury, there's loss of polarity, proteins start to pour out. So that's the kind of picture we would see if we think the patient has rhabdomyolysis. For acute tubular necrosis, very classic is the granular muddy brown cast, which we'll see in the sediments. And then oxalate or uric acid crystals can also be seen in ATN. Red blood cells in the urine, any red blood cell at all in the urine is always pathologic. What we start looking out for is it eumorphic or dysmorphic? If it's eumorphic red blood cells still retaining their form, then it's most likely bleeding along the collecting system. But if it's dysmorphic, that's very classic of glomerulonephritis. If we're seeing white blood cells or white blood cell cast in the urine, then we're thinking acute interstitial nephritis from pyelonephritis or any infection affecting the kidneys. Allergic interstitial nephritis would see eosinophils in the urine, which is usually visualized using the Wright or Hansel stain. Ethylene glycol poisoning, commonly would see calcium oxalate crystals in the urine. So this is just pictures to just help us appreciate what the cast look like. This is the classic muddy brown cast that we see in ATN. This is the granular cast. We can also see this in ATN as well. This is the red cell cast, which can be seen in glomerulonephritis. This is a white cell cast. You can even appreciate the nuclei that are vacuolated and segmented. So this is what we see in cases like pyelonephritis or acute interstitial nephritis. So these are pictures just showing what the crystals look like. This is our classic calcium oxalate crystal. This is the uric acid crystal. This is methotrexate crystal. It's really brown and more like amorphous in nature. Then this is what we see, sulfur-diazine crystals. They're usually fan-like. This is also a sulfur-diazine crystal here. This is a cyclovil crystal. They're usually needle-like in shape. I just put this out just so that we can appreciate what the crystals look like, especially if we're thinking drugs that would cause intratubular obstruction. Okay. So this just still all the crystals that we could find. This is the classic struvite crystal that causes obstruction, staghorn calculi. I think that's indinavir crystal. This is what it looks like. The cyclovir, we already saw that needle-like. Sulfur, they usually look fan shaped. I think that's basically it with regards to the crystals that we see. Okay, so thank you for listening.
Dr. Atta? Dr. Atta, are you in the class?
Doctor, I think, I don't know if he's having some network problem. So we have heard the speaker quite a lucid presentation. I know the question was quite normal, so get that's why she took so much time. So comment, questions, please. Dr. Yahaya. Dr. Yahaya should be in class.
Good morning, ma'am.
Morning. So you coordinate until Dr. Atta comes back. Maybe he's having network issues.
Yes, ma'am. Likely.
Yeah, he's not even in class. Dr. Atta is not even in class.
Okay, ma'am.
Mm.
I'm a bit in around. Yeah. Well done, Doc.
Thank you.
I think the floor is open. Comments, clarifications, and some additions. Well done. It's a nice one, actually.
Thank you.
Yes. Thank you very much. So any other addition?
You can read the comments on the chat box if there are any.
All right, thank you. Sorry, the network logged me out. Okay.
Welcome back, Dr. Atta.
Yeah.
Dr.
Thank
Yahaya,
you, Dr. Selma.
Thank you, Dr. Yahaya,
Okay,
for
yeah.
speaking. Thank you.
Thank you, ma'am.
Yeah, thank you, Dr. Selma, for a wonderful presentation. Thank you so much. Okay, Dr. Chief Shitu wants to say something.
Okay, thank you. Dr. Atta, we thought we lost you. Good, you're back.
Yeah.
Presenter, you did very well. So I didn't start from the exact beginning. I started about when you got to diagnosis of AKI and stuff. Okay. You've spoken very well and you put your information together in a very concise manner. I just wanted to point out a few things so that we all be aware. Presenter, you used a lot of Netscape, right?
Yes, I did. And
yes.
NCBI.
Okay, I could tell because you were using American figures. For instance, the ratio of urea to creatinine. Okay. You know, Americans use BUN, blood urea nitrogen.
Yes.
They don't use serum urea.
Okay.
And that's why their own normal range of urea to creatinine, BUN to creatinine is between 12 and 20. So greater than 20 is pre-renal, less than 12 is intrinsic, right?
Yes.
Yes. Okay, but because we don't use BUN, we use more of serum urea proper, then the ratio is a bit different, and the ratio is between 100 and 40. So 100, greater than 100 to 1 is pre-renal, less than 40 to 1 is intrinsic, and anywhere in the middle is normal or post renal. Then, presenter, I just want to ask you a question. Must you have a reduction in GFR to have an AKI?
Okay, no, sir, because creatinine and GFR are very late indicators of acute kidney injury. So sometimes the GFR might actually be normal, but there's actually an ongoing damage already, and that's why we have those early biomarkers that can help predict AKI early enough before the GFR starts to get reduced.
Okay. I understand your angle, but I just want to ask another question. The indicators that point towards whether somebody has an AKI or not, that is internationally acceptable, must you have a reduction in GFR?
Okay.
Sorry, Dr. Shitu, you're just asking her, how do you diagnose AKI? So how do you diagnose AKI?
How do you diagnose an AKI? Okay,
diagnosis of AKI, we can actually, is actually according to KDIGO, which they've put out a new criteria. You actually, the reduction in GFR actually is one of the criteria for diagnosing AKI. I should have put.
Now, so I don't waste the time. Okay. You must. In fact, in the definition, there is a reduction in GFR that leads to the accumulation of the nitrogenous waste products. Okay. And that is why, regardless of the etiology of AKI, there is always, if you look at pathophysiology, regardless of the etiology, there is always a reduction in renal blood flow, either directly or indirectly. And hence why the GFR must go. That's why creatinine must rise, or urine output must go down. So in other words, there has to be some form of reduction and pulmonary filtration. Now, what those early markers do, because we only use creatinine as a way of assessing GFR. Okay, there are other ways to assess GFR, but many of them are not clinically applicable most times. Okay, or not readily available in our own environment, but there are other ways. A good example is cystatin C. Okay, yes. So I just want everyone to understand that you need to have that. You need to have reduction in GFR for you to say it's truly an AKI or suggest that. Now, the early markers, what they do is they tell us the initiation of the injury, and they always point out that. So I just want to put that there. Then when you were talking about how you go ahead to manage an AKI, please, there's one statement you must always make. Early referral to a nephrologist. Never leave that out. Okay. I would like my patient to have early referral to a nephrologist, because we all know in AKI, even the nephrologist, right? What he's doing is just ushering the kidney back to recovery. We don't tell the kidney to wake up. Okay, we just usher it to recovery by removing whatever is causing it in the first place, and then removing complications and factors that may also cause the AKI to persist. And then with the hope that the injury has not gotten to the level of damaging the cortex. It has been only restricted perhaps to the medulla, and there is no significant damage to the cortex, because that's the only way a person can make a full recovery. So I just want to put that there. Then in your management, that means that in your management there's a lot of supportive therapy. Okay. Nursing, adequate nursing care. Okay. Nutrition, hydration. You need to point out all those things, and even physiotherapy and stuff like that. Okay, because you're basically ushering the person back to recovery, right? By removing all those factors. But you must state that early identification of the etiology and prompt management, where possible, must be instituted. Okay, so those are just the things that we just like to add. Okay, all right. Well, well done. Well done.
Yeah, thank you very much, sir, for a rich.
Sorry, Dr. Aka?
Yes, sir.
Hello? Yeah, let me just
Yes,
ask them. You know, most of the time when Chief Shitu talks, there's nothing much to add again. But I must first commend the presenter. She really had a very lucid presentation. I loved her presentation, and the way she broke things down, classified them, was really very rich and easy to follow and understand. I think one of the little issues I had with her presentation was when she was behaving as if she was interchanging azotemia with uremia. We don't really do that. Azotemia is more like elevated urea, in short. Why uremia is a syndrome? It's a syndrome that talks about the clinical signs and symptoms that are the result of elevated uremic toxins. Not urea, uremic toxins. Okay. And the truth is that if you push a nephrologist, the nephrologist will tell you that urea is really not intrinsically toxic. Okay. The same with creatinine. And that's why we don't manage the numbers. It's not, we don't really manage the numbers. Urea can be elevated, creatinine elevated, yet we are not too concerned, especially if the person is not having uremic symptoms. Okay.
Yes, sir.
And so please don't use them interchangeably. I saw your indication for dialysis as elevated azotemia. Fine, it's okay to say anyway, and then that part of it, please. The indications for dialysis are basically the same for CKD. And when you want to talk about it, please, you can talk about those things. Talk about clinical indications, talk about biochemical indicators, talk about hypercatabolic states. That's fine. Okay, so that might be a little place you need to adjust in the presentation. Okay. So I think those are my little comments. Thank you. You've talked about the pathophysiology quite well. Your pathophysiology too, I would say it wasn't rich enough, but you tried. Sometimes when you're talking about the pathophysiology, you might need to talk about things like the net filtration pressure. Okay. When you consider the contributors to the net filtration pressure. Okay, so talk about the hydrostatic pressure, the oncotic pressures across the filtration barrier. So that's why Chief was telling you that GFR has to be reduced in AKI, because it is when there's an abnormality of the net filtration pressure, when it reduces somehow, whether it is from a prerenal, an intrinsic, or a postrenal cause, it leads to a reduction in the GFR. So this reduction in GFR that is occurring acutely is what is actually the AKI. Okay. All right.
Thank you so much, sir.
Yeah, thank you very much, sir, for the presentation. Sorry for the rich contribution, sir. Thank you also, Thelma, for wonderful presentation. Can you unshare so that the next person can share his or her screen while I read? Okay, Dr. Kopi. Okay, I didn't see that. Okay, so Dr. Kopi, you can contribute while the second presenter should start sharing their screen. Okay. Steve Kopi.
Dr. Atta, there are so many comments in the chat. You have to read them.
I'll read them out. Dr. Kopi raised his hand, so that's why I wanted him to go first before I will read the comments. Okay. Okay, while we're waiting for him, so I'll just read some of the comments on in the chat box. Okay. Dr. Victor said we forgot to add calcium gluconate hyperkalemia. Okay. Dr. Ukam said it was an excellent presentation. We seem to have some interference. Okay. All right. Thank you. Okay, Dr. Ekede, so thank you so much for the wonderful presentation. Please, can you label one of the slides showing casts? Okay, so probably you labeled the slides where you showed us all those casts, okay, urinary casts. So probably label them before you post the presentation for us. And then Dr. Fee say thank you for the extensive presentation. So basically, it just comment. Okay, then Dr. Yasa say in the US, the only FDA-approved biomarkers for early AKI predictions are the cell cycle arrest biomarkers, insulin-like growth factor, binding protein 7, and tissue inhibitor metalloproteinases. Dr. Lalikan say thank you for the lucid presentation. Is rifle and or AKI staging for AKI still being used in the newer guideline? So he's asking if the rifle or AKI staging for AKI is still being used in the newer guidelines. That's the only question. The others are just contributions. So Dr. Talbot.
Sure, you can save our time. So I will just contribute on that last question, please, Dr. Shitu.
Okay.
The thing is that right now we don't use either of them anymore. Okay, what we use is we use the KDIGO guideline. And the KDIGO guideline basically married rifle and AKI. Okay, because if you look through the AKI guideline of KDIGO, you will see why they merged it. Because there are a group of patients that will be missed if you use just rifle. Another group of patients would also be missed if you use just the AKI. So they basically matched it up and now created the KDIGO classification, so to speak.
Sorry, hello, Chief Shitu.
Yes.
Hello, Chief Shitu. Sorry to cut you.
It
is actually 10% for rifle, 15% for AKI, those that are missed. So that's why the KDGO came up. Thanks.
KDGO matched it up together. So if you look to that guideline, it's well explained. So I usually tell people if you want to understand AKI, just go and read that KDGO AKI guideline. It's easy to read, actually, very easy to read. Okay, and that so there's what we use now is the KDGO AKI classification. Okay, all right.
All right, thank you very much, sir, for the clarification, sir. Okay, next presenter, please. If you're in class, please, can you indicate so that we know? Dr. Taiwo, Dr. Adibola, Dr. Gift, are you in class?
Good morning, Dr. Atta.
Yeah, good morning.
In class, I'm trying to log into my system. I'm in the waiting room.
What is your name appearing on that? What's your name on the waiting room?
I think I've logged that in Gift, right?
Yes, sir.
Yeah.
Okay.
But you should have logged in, say so. Eh?
We can pause the recording, please, so that we'll wait for her.
Dr. Atahaba, the other people that are supposed to present.
Yes,
Hello, good morning, sir. Sir, I wanted to ask what the network logged me out. Hello, good morning, Chief Remigo, sir.
Yeah, we can hear.
I think Dr. Remigo, what he wants to know is, I think the way to just break it down for him is this. See, when we say isothermia, we're just referring to how much urea is in the body, right? So when we say there's isothermia, it means there's a lot of urea in the body. However, uremia itself are the clinical features of the accumulation of nitrogenous wastes, not just urea. Even though urea is the one that is one of them, but it's not the only one. Do you understand? So it may not, your urea may even rise and not have much impact on you to cause symptoms in form of uremia. Do you understand? It's like when there's hepatic encephalopathy, we talk about ammonium most times. But the other ones, right?
Okay.
Can I remember them? I know that is it methionine, there is ornithine, there are so many things that cause uric encephalopathy to do that, right? To develop, sorry. Okay. But ammonium is the one we tend to hold on to because it's the one that is the easiest to explain. Okay. So the same thing with uremia. There are other things apart from urea that are responsible for uremia.
Okay, I get it. Yeah, I get it. Thank you.
Thank you so much. So many times you cannot ascribe azothermia to uremia because it's possible that someone is azothermic but not uremic.
Okay. All right. Okay. Thank you.
All right.
Thank you, sir.
Thank you. Yeah, thank you very much, sir. So, Dr. Gibbs, you can go ahead.
Good morning, my teachers. Good morning, my colleagues. I'll be presenting WAP April 2021 General Medicine question 9. Sorry, my slide is not moving.
Did you share your screen?
Can you see my screen?
Yeah, we can see your screen. Or we can see your slide. Yes.
Okay, that's not moving.
Did you share your screen or your slide? Let me go back.
Arachnoid hemorrhage. 20-year-old female, severe headache, vomiting, and blood pressure of 180/500. List 5 risk factors in her that predispose her to SAH, subarachnoid hemorrhage. How will you manage? List 2 complications and manage them. Then what is the pathophysiology of hyponatremia?
Hello, Dr. Wait.
Hello? Hello?
Hello, can I be heard? Doctor, can you hear me?
Yes, we can hear.
Can you hear me?
Yes, we can hear you. I'm just looking at the time. You barely have 7 minutes and interaction for us to interact and all. I don't want us to rush through it. It's already 7:53. I don't want us to rush through it. Is it possible for you to come in tomorrow morning and take this question? If you have challenges with your slides, share it on the group early enough. So once you come in and then any challenge, someone quickly will share for you. Because with this timing, we are going to rush through that question and we never can tell what will be recorded. So please, let's take it tomorrow, please. Sorry.
Tomorrow is supposed to be dissertation.
So. Oh, it's true. Oh, yeah. It's true.
Yeah,
I don't know. It's already 7:54. That first question was so lucid that I would not. That was so rich to me. I love it. I really love it. So time is up already. Once it's 8, most people morning review, a lot of things happen already. So many people might not interact so much. I know this particular recall, they have STEM 1, STEM 2, sometimes STEM 3. So, but
okay,
what do you think, sir? Chief, wait, okay.
Yeah, I think
we spend time already. Let's just wait till Monday. So please, you help us take this question again on Monday, please.
Okay.
So we can do just to the topic.
Okay, ma. So, Dr. Gift, you take the presentation on Monday. So, we hand over to Dr. Christopher and teachers to close the class.
Thank you, Dr. Atta, Dr. Yeah. The first presenter, thank you for the lucid presentation. Dr. Gift, thank you. Sorry once again, we apologize. We want it to be an interactive session, but we don't just want to count numbers. We've answered 20 questions. No, let it be that we've answered 5 good in a quality manner. Everybody benefits from it. So thank you so much. Our teachers and Chief Koke, Chief Remigos, Chief Chitu, Dr. Fatima, Dr. Kopi, Dr. Atta, Dr. Yaya, thank you. Dr. Jennifer, thank you so much, everyone. We appreciate your presence. Participants, thank you. So we'll close the class. Chief Koki, Chief Koki, yeah, Chief Chitu today because of dissertation tomorrow. Chief Koki, Chief Remigus, Chief Chitu, Chief Koki, please just close the class.
All right. Okay, is it Chief? Who did you call? Did you call me?
Maybe I should talk first then. Was that called?
Okay, go ahead.
Sorry.
I was confused at one point.
I was logged out. I don't know if that question that was asked was answered.
The question of
uremic toxins.
Yes, I sorted it out.
Okay. Thank you, Chief.
Yeah.
So, all right. Thank you, everyone. It has been a good one today. So let's just keep it up. please let's endeavor to attend tomorrow's class. Let's just push on. I know it's just a few more days to the exams. Please, for these few more days, what I would prefer is those that are going for this exam,